Welcome and thank you for joining us today. I'm Melissa Bombeck with the ANA, and we're excited to welcome Dr. Michael Brisman of NSPC Brain and Spine Surgery in New York. Today, we are going to talk about the diagnosis of and the advanced treatment options for acoustic neuroma. Let me review a few things about today's presentation before we get started. If you have questions, please type them into the comment section, and we'll get to as many as we can after Dr. Brisman's talk. Also, you should see captions at the bottom of your screen. If you don't, you may need to activate them on your computer. And finally, we are recording today's presentation and we'll have it uploaded to the ANA website in the next day or so. We'll also add permanent captions to the recording, and you'll see those in about a week. Our thanks to all of our annual sponsors whose support and partnership help advance acoustic neuroma education as well as increase awareness. Now, I'd like to introduce our speaker. After receiving his undergraduate degree with high honors in biology from Harvard University, Dr. Brisman obtained his medical degree from Columbia College of Physicians and Surgeons. He then completed a general surgery internship and neurological surgery residency at the Mount Sinai Medical Center in New York City, where he was appointed chief resident in his final year of residency. Dr. Brisman specializes in the treatment of acoustic neuromas, pituitary tumors, and other primary brain tumors, in addition to trigeminal neuralgia and related facial pain conditions. He has served as co-director of the Neuroscience Institute at NYU Langone, Long Island, and is the co-medical director of Long Island Gamma Knife Center at Mount Sinai, South Nassau in Oceanside, New York. Okay, we're ready to get started. I will stop sharing my screen and turn the webinar over to Dr. Brisman. So let me get to where I need to be.
Okay. Thank you very much, and I hope everyone is well and keeping safe these days in this the situation we're in. I'm a neurosurgeon. My father was a neurosurgeon, and my brother is also a neurosurgeon. He works with me. I'm part of a very large group of brain and spine surgeons. We have like 22 surgeons out here on Long Island, New York. And I do specialize in brain tumors and trigeminal neuralgia, facial pain. And I do both regular surgery as well as radiosurgery, the super focused radiation, which is a much less invasive way of treating some of these problems and is appropriate in a lot of cases. So we opened our Gamma Knife Center on Long Island, which was the first Gamma Knife on Long Island. And it's almost 20 years ago. In a few months, it'll be the 20-year anniversary. And we've treated thousands of people on that. And I'm going to talk to you about acoustic neuromas. Obviously, different people have different philosophies, whether it's different surgeons or radiation doctors or neurologists or ENT doctors. And I'm certainly, you know, I think there's a wide range of acceptable ideas out there and acceptable ways of doing things. I'm just going to give you my philosophy and then we'll take questions. So we'll go on. Let's see. Right here. Hold on, I'm having trouble moving my screen there. Hold on. Okay. Okay, great. So acoustic neuromas, these are almost always benign tumors that arise, here's my little pointer, from this little canal here where the two nerves usually run, the facial nerve, which controls movement of the face, and the cochlear nerve, which is involved in hearing and balance. And the tumors usually arise from that canal, but then can grow outward into this area here. This part of the brain, the back part of the brain, is called the cerebellum. And this here is the middle of the brainstem called the pons. So the area where these can grow into is an area called the cerebellopontine angle. This is a fairly large tumor that's causing compression on the brainstem and on the cerebellum. Here's a look if we were to look from the top of the head down. It's sort of, if you went like just straight inward from the ear, there's where the tumor can be. It comes out of this canal here. Here on this side, you see where the normal 7th and 8th, the facial nerve and the hearing nerve go out from the brainstem through this the canal, at which this is the normal side. Okay. So the presentation of these tumors includes decreased hearing, can also be tinnitus or ringing in the ear, can include balance problems, because again, part of the hearing nerve is involved in dizziness and balance. And if it's big enough, it can compress the trigeminal nerve, and there can be numbness of the face. There could be headaches. I would say that because of the proliferation of MRIs, now in the United States, we have an MRI in every block. These are overwhelmingly found when they're pretty small and early. So it used to be, you might not find such a tumor until it was enormous, but that's rare. We're usually finding them small or even tiny. The diagnosis is made really with imaging of the brain, primarily with an MRI, with and without gadolinium contrast material, with the IV contrast. And it can focus on the internal auditory canal, that little canal where the nerves run into the bone, for very small tumors. And sometimes we'll even see tumors as small as 2 millimeters, like the size of a bead. And usually we leave those alone, but the tumors can range, again, from anywhere from 2 millimeters to 4 or 5 centimeters in size. The diagnosis can be made by, the internist can order the MRI, sometimes a neurologist, sometimes an otolaryngologist or ENT doctor, sometimes neurosurgeon or audiologist. But again, these are usually picked up earlier these days. Someone starts to say, I've noticed my hearing in one ear is a little decreased, or I'm having some ringing in my ear, and usually that prompts an imaging study. The natural history of these is they tend to grow slowly. Some grow very, very slowly, and you can follow them for 20 years and they barely budge. Some grow faster and can end up getting as big as that tumor I showed you before. And the natural history is also that people do tend to lose hearing in that ear, which can be stepwise. So it could be all of a sudden you wake up and it's decreased. It may improve then again. It may decrease suddenly and not recover, or or it can gradually decrease, but it's a little bit unpredictable. But over time, people do often lose hearing in that ear, regardless of necessarily how big the tumor is. So you can have a small tumor and have pretty poor hearing, or you can have a pretty moderate sized tumor and the hearing can still be intact. So it's a little unpredictable with that. So options for the tumor itself. We could talk about, things that one could do about hearing loss or dizziness separately. But as far as dealing with the tumor, either one could watch it, observe the tumor, or one could operate on the tumor, cut it out or cut out part of it, or one could do this super focused radiation or radiosurgery. So those are generally the categories of treatments for the tumor itself that one could do to make the tumor go away or deal with the tumor itself. So just to discuss anatomy, like what kind of stuff is in that cerebellopontine angle, and the answer is there's a lot of important things in there. So first is there's the eighth nerve, which has the component of hearing, but also a vestibular component of balance. And these actually, even though they're called acoustic neuromas, the proper term is probably vestibular schwannomas. They usually arise from the vestibular portion of the nerve. And they're probably more likely schwannomas than neuromas, but nonetheless, the terms are used interchangeably. The seventh nerve or facial nerve, which is rarely affected by the natural history of this tumor, although can certainly be affected by surgery, certainly at risk if one attempts to remove this tumor completely, particularly for bigger tumors. There's the cerebellum and the pons. The cerebellum is involved in balance, involved in coordinating movements. The pons or the brainstem, is critical for moving your arms and legs, feeling your arms and legs, being awake. So that's pretty critical. The fifth nerve is involved primarily in sensation of the face. And then lower down, you have nerves, the lower cranial nerves are 9, 10, and 11, which are involved in being able to swallow properly so you don't aspirate or get a pneumonia. So there's a lot of important things, and that's not to mention the arteries and veins there. So these tumors on MRI, obviously there's a wide range of them. So this is a pretty small tumor that is primarily within the internal auditory canal, the IAC. And here's a tumor that got very, very big and is causing a lot of compression. And certainly one might reasonably think to operate on this tumor, because this is a very big tumor and rare that we see them this big these days. This is much more commonly what we see. I mean, it's stuff, like smaller tumors here where you see the tumor is growing from the internal auditory canal, is starting to grow into the cerebellopontine angle. Here's one that's a little bit bigger. And this is much more commonly what we'll see. Again, some more pictures on the MRI. Here's a tumor, again, an acoustic neuroma. It isn't growing too much into the canal here. Here's a very big one that's causing some compression. But again, the tumors that are found when they're gigantic are pretty rare. And if they become big enough, this is the fourth ventricle. Is the brain makes its own watery fluid called cerebrospinal fluid that bathes the brain and protects it against impact. So that fluid drains through this space here. So conceivably, in rare cases, if the tumor is enormous enough, it could compress that drainage pathway, and a person could get buildup of fluid in the brain called hydrocephalus, which could be life-threatening. Very, very rare that they get to that point. So as far as surgery goes, I mean, there are three general approaches. I mean, one is the suboccipital, so where we go behind the head. One second, sorry. Retrosigmoid, where we work behind the sigmoid vein, which I think is the main method of operating if you're going to operate at all. And I'll also preface by saying, in my opinion, the only reason to operate on these now is if they're enormous. I mean, otherwise, either leaving it alone or doing the focused radiation is equivalent. And I'm not sure why one would do a giant operation if one could just do a little outpatient procedure. But this is the procedure that I think is the only one that even makes sense nowadays, is this suboccipital one. The translabyrinthine is where you go in front of the sigmoid vein, and I'll show you on the next picture. But the problem with this is, and this is sometimes done more by ear, nose, and throat doctors, is you're going through the bone that is necessary for hearing. So if you go this route, you're definitely going to lose hearing no matter what, because you're going through all the hearing structures. So, I mean, this would only be reasonable if you had no hearing at all to start with. And still, I don't know why this would be any better than the first one. And the third option is this subtemporal middle fossa, where you kind of go from the top. And this is only used if the tumor is very, very small. And again, I don't really understand why, if the tumor is super small, I mean, personally, and again, this is my opinion, I would say, why even bother to operate if it's so tiny? But these are all, again, acceptable, perfectly acceptable. But again, the only approach that I think is that I do or would consider reasonable, in my opinion, is this one, the top one, and only if it's a huge tumor. So this is an example of a typical suboccipital retrosigmoid approach that a neurosurgeon would do. My incisions are like, from here, much smaller than this. I don't know, this is a very large incision. Usually it's a much smaller incision, maybe, right behind the ear. And then we open up the dura, the covering of the brain, then you can get to the tumor. The translabyrinthine that goes, there's a vein here, the sigmoid vein. The translabyrinthine goes closer to the ear through the bone directly. And again, that definitely gives up any chance of preserving hearing. And the subtemporal kind of comes in from the top here. So this is sort of showing what an operation would look like. So let's say we've made an incision, we've opened up a piece of bone, we've opened up the dura, the parchment-like layer, the thick layer that covers the brain. This is the cerebellum. This is supposed to be a little draining some of the brain fluid to decompress so we can see things. And then here's sort of a surgical view. And this is the suboccipital route over here, where we're coming in like this. If we were going translabyrinthine, we're kind of going through the bone here, and you sacrifice the hearing structures. And again, the other approach would be kind of coming from above the ear. But so when you look at it, after you've drained off the brain fluid and you have relaxation, here's a little retractor on the brain. Here's the tumor. Here's the fifth nerve, the trigeminal nerve that's involved in hearing. Here's a petrosal vein that often is not that critical. This is the tumor, and this is where the internal auditory canal is. And in the past, if one wanted to get all the tumor out, you would have to drill some of this bone here to get to the internal auditory canal. Here's an important artery. There are two important arteries. There's a superior cerebellar artery up here, an inferior cerebellar artery, an anterior inferior cerebellar artery, and a posterior inferior cerebellar artery that supply the the cerebellum that are critical to preserve. The 9th, 10th, and 11th nerve that are critical. If the 10th nerve is lost, you're not able to swallow properly. And underneath the tumor, usually squished behind it, is the 7th and 8th nerves. So again, and in the past, when there was no focused radiation, people would drill this canal here, would try to take out the entire tumor, would peel the tumor off the 7th and 8th nerve. Often, I mean, usually the hearing is lost if the tumor is big at all. And often people could develop weakness of the face because the 7th nerve is so squished and splayed out by the tumor, it's very fragile. So the point is that this is to be taken very seriously. This is a high risk operation. And my feeling, and I think a lot of other people are starting to think the same way, if a tumor is gigantic, I would just debulk it and not peel it off the nerves and arteries and threaten those critical structures. This is showing without a tumor, just to see the anatomy again. And again, you see here's the 7th and 8th nerve, 9th, 10th, 11th nerve. Pike is the posterior inferior cerebellar artery, supplies the posterior, the inferior, the bottom part of the cerebellum. But the point is that there's a lot of very, very important things in this area that the tiniest problem could be very serious for a person. And it might not even appear in reports of these cases. Like people could be left with terrible dizziness or terrible incisional pain or you know, bad numbness of the face or pain in the face from irritating the trigeminal nerve or whatever, or weakness of the face. There are a lot of all sorts of things that can really, really adversely affect a person from this operation that often don't even get reported. That often the surgical series are like, well, the tumor's out and the MRI looks pretty good. Isn't that good? But to me, this is a much higher risk than the new alternative. This is what it could look. This is often what can happen when one tries to remove 100% of a very large acoustic neuroma, is that there can be facial weakness. And this is a person who has normal movement on this side of the face. You see they're able to smile and this side is very weak. Now, often that gets better over time with surgery if the facial nerve is anatomically preserved, but sometimes not. And there are things that plastic surgeons can do to try to reanimate or fix this problem if it never gets better. But again, I would say my feeling is why even threaten the facial nerve? I feel it shouldn't even be put in jeopardy, which again, if you either don't operate on these people and just do the focused radiation or operate and just debulk the tumor, you don't get into that problem. So risk of surgery, obviously there's a lot of serious risks of this operation, which again, if the tumor is enormous, I think should be done, including hearing loss, which is very common with the surgery. The nerve is very fragile. So, attempts to remove the tumor in entirety, almost, there's often hearing loss that happens immediately. Dizziness, balance issues, face weakness, leaking of fluid, meningitis that can be fatal, chronic headaches I've seen, facial numbness and pain, and even death. So the risk of something serious is several percentage, which is, a serious business. So in my opinion, this newer alternative, what I'm going to call stereotactic radiosurgery or bloodless brain surgery, is the way to go for almost all acoustic neuromas that are going to be treated, other than the enormous ones. This is usually a one-day treatment. People come in, they get the treatment in one morning, focus beams, aim on the tumor, and prevent it from growing further, and they go home that morning, and that's it. And they're usually cured. And if it were me, that's what I would do for most of the time. So the stereotactic radiosurgery concept was invented by a Swedish neurosurgeon, Dr. Lars Leksell, and he invented this machine called the Gamma Knife. But I think our understanding of the Gamma Knife has increased exponentially in the last 20 years because, we have MRIs. We could see what we were aiming at. Before the 1990s, you couldn't even see what you were focusing on. So it was harder to judge the outcome, and we didn't know the right doses. So stereotactic radiosurgery is a non-invasive technique usually to deliver a single very high dose of radiation to a limited, well-defined target while avoiding nearby critical structures. So it's basically a way of treating something inside the body with, without going into the body. And I think it's pretty remarkable. So this is an example of one of the latest machines of Gamma Knife called the Perfection. And over the last 20 years, we've updated our machine several times. But the general concept is the person lies in this table. After we put a helmet on the head, I have an anesthesiologist sedate the person. We give local. We put little pins in the head to hold the head still. The person is sedated for 5 minutes while we do that. They get an MRI. Then they lie in this table here, and people can be sedated as much as they want. Some people like to be asleep for the MRI. Some people like to be asleep for this part too. We have an anesthesiologist there helping them to make them feel comfortable. Some people are more claustrophobic. And then everyone steps out of the room. These doors open. They slide into the machine with just the head in the machine for 45 minutes. And then that's it. Then they go home. So this is the inside of the machine where there are these cobalt beams, gamma beams, that are all focused on a central point. And obviously, in the point of the treatment is we put the tumor at the focal point, and it moves a little bit around to get the different parts of the tumor. And that is just enough radiation to obliterate the tumor. And in cases of benign tumors like acoustic neuromas, we usually only need a very low dose. So I want to just show you some of the things that we do with radiosurgery. Now, I use a lot of different radiosurgery machines. The Gamma Knife is really single session treatment. And I think it's the gold standard for that stuff. Now, there are other machines I use like CyberKnife, Novalis, and TrueBeam, other things that are called linear accelerators that use X-rays instead of gamma rays that kind of do similar things. They can also treat in fractions, so they can treat in 5 sessions, and they can also treat spine and other body parts. So if I want to treat a spine tumor, I use something else. If I want to treat in 5 sessions, I use one of these linacs or linear accelerators, which is what treats most radiation treatments for the body. But for most single head treatments, I use Gamma Knife. So here's an example of Gamma Knife treatment for a patient who had 3 brain metastases from lung cancer. And the cancers can spread to the brain. And in the past, the treatment was to do whole brain radiation, to radiate the whole head. But that would take a month. It caused hair loss. It caused memory impairment. With Gamma Knife, we're able to focus right on this tumor, this third tumor, and it just zaps those tumors away. We use a higher dose for malignant tumors, for cancerous tumors. And these were this patient's images 6 years later. You see the duration and how successful it was. Now, obviously, for people with primary cancers like lung cancer, breast cancer, a lot of the success depends on how well the oncologist can control the disease in the body. Because, I mean, that's a separate matter. But as far as controlling the disease in the brain, Gamma Knife is very effective. And we repeat images. If something new pops up, we can retreat it. This is a physician who came to me from Manhattan who had a moderate-sized meningioma, another benign tumor that arises from the meninges, the covering layer of the brain. It was getting bigger, had a few little cystic component or fluid component. And, I said, look, a lot of people would operate on this, but we could do the focused radiation. She's like, that's what I want. So because hers was a little bigger, I did it in 5 sessions with my radiation oncology friend. And here's several years later, it had shrunk. She felt fine. She's been very happy. So that's another benign tumor we treated. This is a patient who I had removed another benign tumor, a pituitary tumor. These tumors arise here by the pituitary gland. If they get big enough, they can press on the optic nerve here and can cause vision problems. And he had a recurrence. And often we don't get all the tumor out. Some tumor can grow back. Here's a recurrence, these images. And we did a super focused treatment. And one of the beauties of this treatment is the radiation falls off very fast. So we can make sure that the optic nerves and other structures got minimal radiation dosage. And here he is 3 years later, the tumor's like totally gone. Here's a picture of somebody who this was a teenager who had an abnormality, an abnormal tangle of blood vessels in the brain called an arteriovenous malformation or AVM. and she had symptoms from that. And superfocused radiation can work for that too. And it causes those abnormal vessels to clot off over time. So they're no longer a risk of bleeding or causing seizures. And here we did the focused radiation right to that tangle of vessels. An operation which could be done would be super high risk. These bleed like you can't believe. And this was a one-day treatment. And this is a few years later, the thing is totally gone. And we can also use it for trigeminal neuralgia sometimes, particularly for older patients, patients who have multiple sclerosis, who have had other treatments. We can aim, these are people who have severe shocks of pain in the face, and they benefit if we injure the nerve a little bit. And here's the brainstem, here's the trigeminal nerve. We aim the beams on the nerve for 40, 50 minutes. And this is a side view of the nerve, and that's enough to injure the nerve, just enough to get rid of the pain. And this fellow I saw recently, 15 years later, he said, I'm still pain-free, but his back hurts. So I was talking to him about his back, but this can also be very effective. It can recur, it may need repeat treatments, but this is an option for that as well. So types of radiosurgery for acoustic neuromas can include gamma knife, which emits gamma rays, but it can also include linear accelerators, which emit X-rays. And there's no difference between a certain dose of gamma rays or X-rays. I mean, one unit of dose of X-ray is the same as 1 unit dose of a gamma ray. What really is important is how conformal is the treatment to the tumor, how rapid is the fall off of the tumor, and the experience of the person using it. I personally believe that the best results are going to come from highly experienced neurosurgeons who do lots and lots of gamma knife, as well as feel comfortable doing lots of open surgery. I mean, and that's just my opinion. I feel that the radiation oncologists are often trained really mostly in traditional treatments, not super focused radiation. And even when they're trained a bit in that, it's not their main focus. They don't understand necessarily, could this person get surgery? How hard would it be to do the surgery? And I think they're even less knowledgeable about benign diseases. That's why they're called radiation oncologists. They deal specifically with oncology or cancer. So I like it when I am the guy who is deciding about the treatment, planning the treatment, deciding the dosage and everything. And one of my concerns and issues with the linac treatments is that often the radiation oncologists kind of want to do a little bit of their own thing. And I mean, I like to be the one making all the decisions. But linear accelerator, you can have single session, which is still radiosurgery. And there's also radiosurgery is up to 5 sessions. So you might see it done in 3 or 5 sessions. And those can also be done for acoustic neuromas. You would use lower doses then. And then you have typical fractionation, which is the typical way you would fractionate if you were radiating your whole head or for different types of tumors in the rest of the body, which might be done over several weeks. So I feel that the gold standard for radiosurgery for single session brain treatments for acoustic neuromas is gamma knife. That's what I use. But I think it's, again, certainly, I feel it's the most accurate, most consistent, that has the most data. That having been said, I think it's certainly acceptable and okay to do other types. I think it's acceptable and okay to operate on these, to watch them. There are many different ways of doing it. I can only tell you, my experience. I've been doing this, out of, or whatever. I mean, 23 years I've been out here in New York practicing, and what I would do in my own head. So one thing we've learned of importance is that the radiation dose is critical to the edge of the tumor. So it really has to be at 12 to 13 gray is sort of the magic range for acoustic neuromas. If you go over 14, and they did this 20, 30 years ago, you can start getting weakness of the face and facial nerve problems. So we never do that. And under 12 gray to the edge, you don't get as good control. So 12 to 13 gray is really the optimum range to be in. And one might even err a little bit on the lower side if there's useful hearing to start with. One might aim for like 12.5 gray, whereas if the person has no hearing, we'd probably give 13 gray. So this is one of my first patients I treated 20 years ago. But one of the things I want you to see is one, and these are the key components to radiosurgery, is the conformality. That is to say, the radiation is really right on the tumor, and that's where we want to be. And the other key thing is that there's a very rapid fall off. So let's say the 50% is the 50% of the maximum dose. Let's say the maximum is somewhere in the middle, and you see it goes to 40 to 30. It falls off very quickly. So the total dosage, the normal brain is pretty minimal within a few millimeters. So now I'm going to show you some of my cases. This is a gamma knife patient I treated who had a small tumor. She had some decreased hearing. We gave it 13 gray to the edge. We treated her about, I think it was 13, 14 years ago, one of my earlier patients. And the tumor, this was the day of treatment. This is her latest film, which shows the tumor never got bigger. And also her hearing has been preserved at the level it started with. So usually we say that there's about a 60 to 70% chance of preserving the hearing at the level that you go in with. If you go in with no hearing, you're probably not going to have hearing afterwards. Although I have had patients who their hearing improved. And the better the hearing is to start with, more likely it's going to be preserved. But again, I would say most studies show, and my experience, about 60 to 70% will preserve at the level that it is. Some will decrease some, and some will still lose hearing, no matter, even with the treatment. But she did super. This is a woman who saw me, who I treated, and she has a moderate sized tumor. We did a treatment, we did 13 gray for her. And this is several years later. You see the tumor is shrunk. It's not gone, but it's just inactive, dead scar tissue. It's not bothering her. Her hearing decreased some from here, but she still does have hearing, which she certainly wouldn't have if she were operated on, because it's very hard to preserve hearing with big tumors. And she's doing great. This is a patient who has a genetic disorder called neurofibromatosis type 2, or NF2. So most acoustic neuromas are just sporadic. I mean, you have it, but none of your relatives that came before you or after you have it or are going to get it. Whereas NF2, neurofibromatosis type 2, is a genetic disorder that your parent may have had, your child may have, where people have acoustic neuromas on both sides. And they can get other tumors too. And in the past, when people operate on these people on both sides, I mean, you can imagine they could end up with a lot of deficits and problems and weakness on both sides. So this was a young girl, her father had NF2. I treated this tumor. She had minimal hearing to start with, and this tumor was small. And then years later, this tumor had dramatically shrunk and her hearing actually improved. But again, I would say that's rare for that to happen. Her hearing, which was like 20% of normal here, now it's like almost normal. And then this tumor was getting a bit bigger recently. We recently treated this tumor as well, and she's doing well. And she also had 1 or 2 little tumors in her spine, and I treated those on a different machine. But again, she's done beautifully. And these people get lots of tumors. And in the past, they would get lots of operations, and you can imagine they did not do as well. She looks perfect. And since her 2 treatments, she's had 2 children. She's doing beautifully. She's not quite 30 yet. This is a picture of a more recent treatment I did of a person who had good hearing. And one of the things that we've learned about hearing preservation, so if you ask me what's one of the newer concepts, is not just the dosage of the tumor, which I think we tend to go a little lower. If a person has very good, decent hearing to start with, we aim for more like 12.5, but also the notion of minimizing the dosage to the cochlea. So the cochlea, which is an important component of the hearing apparatus, is better seen on a different sequence. We do a T2, a different weighted sequence on the MRI. We contour it out, and then we specifically, are able to do a treatment that minimizes the dose of the cochlea. And it's been found that really has a big impact on preserving the hearing. So this is that same patient showing the tumor from bottom to top or top to bottom. Here's the trigeminal nerve at the top. I'm sorry. Here's the tumor down below. Here's the blue is the cochlea. And you see, again, I try to do a super as close I can to the tumor as possible. We've minimized the dosage to the cochlea. And I think that seems to, new evidence suggests that gives the best results. This is an example of a very big tumor that I operate on this past year. And again, I'm going to tell you that I think very few acoustic neuromas, in my opinion, if it were in my head, would I operate. There are some that are really, really big. This was a woman who was 70, who had an acoustic neuroma that was followed. It got a lot bigger. It had bleeding into it. She was very unsteady. So yeah, so I operate on her. The standard suboccipital retrosigmoid. So here's the sigmoid sinus, the vein. We go behind the vein here. Here was the approach. And the operation that I did, and I think a lot of people are starting to agree with this idea, is take out most of the tumor. There's no need to drill the canal and take this tiny piece. There's no need to scrape the tumor off the critical facial nerve, off the hearing nerve, off the brainstem, off the critical arteries. I mean, in my training, this was 25, 30 years ago, all the acoustic neuromas, and we treat a lot of them, all got surgery. And a lot of people did well, but a lot lost hearing. A lot of people had facial weakness. Sometimes, often would get better to some degree. And occasionally someone would get meningitis and die or have a stroke. I mean, things could happen. This approach, when it is necessary, I think this operation took only like 3 hours, much shorter operation, because the tough part where you're peeling it off, the flattened, squished facial nerve, which is like wet toilet paper when it's been compressed over many years by an enormous tumor, all we did was debulk the tumor. This patient went home a few days later. She did great. Not only was she totally intact neurologically, but she came in with useful hearing, which was totally the same as it was going in. She still had useful hearing. And again, the key was we didn't try to remove every last drop of the tumor. It was just a debulking procedure. And this part we can easily treat with the focused radiation. Again, my opinion, if somebody wants to take out all the tumor, that's fine. If somebody wants to operate on small tumors, that's acceptable, but they're different. I'm giving you my thought. Follow-up, I follow up everybody with MRIs to see what's going on. Often, initially after a gamma knife treatment, you'll see some central necrosis. The inner part of the tumor starts to die off. It may look darker than the edges of the tumor before it then ultimately shrinks. And if a person has a little symptom, we can give some steroids. And I would say this treatment works and cures the tumor 95% of the time. So about 5% of the time, these tumors will still grow. And then the option is to either retreat with gamma knife, which is my preference, or sometimes you have no choice but to operate. But I would say that is very, very rare. I would say with gamma knife, and I've treated a lot, I don't know, 150, 200 patients. I've had nobody who has had any facial weakness. I mean, I had one person who had like the most minimal twinge of the face or weakness for a week and it got better. I've had nobody gets infections. Nobody gets bleeding. Nobody dies. Now, one argument that people have made, I guess, for the surgery is they'll say, well, you're using radiation. There is a tiny, tiny, tiny risk of developing a cancer. And I don't deny that. I mean, that is true. If you look in the literature, of 100,000 people who had gamma knife, are there a few that have developed cancer? I mean, it's possible, just like getting CAT scans or getting x-rays or walking outside in the sunlight, there's a tiny chance. But I mean, if you say, look, gamma knife has a 1 in 10,000 chance of developing a cancer, or 1 in 100,000, and I tell you that your chance of dying or having a death from the surgery is 1 in 100, or having a major complication is 5, 10, 15%. I mean, to me, it's no contest. So, and there's certainly long history of results for gamma knife. I mean, I'm going to show you studies that go back. We've had studies for 20 years. This is showing, again, excellent tumor control. This was done, 20 years ago. Major permanent facial weakness, 0. I've never had anyone have any facial weakness. Hearing level maintained. Well, again, I would say most of the time, I'd say 60 to 70%. And it depends how big the tumor is and what the hearing is to start with. This is another study from 20 years ago. Again, outstanding control, major weakness. We now really see none because we know what the right dose is. Hearing level maintained, again, often, but not always. So that's my talk. So I would say in conclusion, tumors that are 5 centimeters or less, I leave alone. Tumors that seem stable over time. If somebody says, look, let's watch this and it's been stable for a long time, I think that's fine to watch it. Tumors in somebody who's with limited life expectancy, someone who's 85, they found a little tumor, I'll say, look, let's just follow it. Tumors that are gigantic, I mean, and again, it's not a one measurement, it's 3 dimensions. So you say my tumor is 3 centimeters, I mean, are you including the 1.5 centimeters that was in the canal? And each person's brain is different. Some is going to be more compressed than others. But if it's really huge, in rare cases, then I would debulk the tumor, and then I would treat the remainder with Gamma knife. And otherwise, again, most people I do Gamma knife. If it's on the edge of being a borderline operate versus not, I might treat in 5 sessions, like a fractionated treatment over 5 sessions. But again, in my opinion, the results for the Gamma knife and superfocused radiation are comparable to the efficacy of surgery with dramatically lower risk profile. So I understand, the argument, well, you could get cancer, but I mean, again, the risk of you dying of cancer from Gamma knife treatment for an acoustic neuroma is minuscule compared to the risk of someone trying to operate on this, even doing just a debulking. But so those are some of my thoughts. Again, these are just my thoughts. I think a lot of people have other opinions, and ideas change over time. Like there was a time when people would remove their gallbladder. There was an enormous incision in the abdomen, going like your whole right side of your abdomen was cut open. And then they ultimately started doing it laparoscopically. When I had my gallbladder out, they just made a little incision in my belly button, and you don't even see the incision. And initially the people who were doing the open procedure and the patients were in the hospital for 2 weeks, they said, look, ours is the gold standard. But over time, people started to say, come on now. I mean, there's ample evidence at this point that, if we could do the same thing through your belly button, why not? And I went home the next day, and that was only after I begged my surgeon wanted to send me home the same night. And I said, look, you know what? The surgery finished late. Can I just stay till morning? He said, okay. But again, the treatments for acoustics, they go home the same day. And I'm now, I guess, open for questions. And maybe I'll stop and share, and I'm happy to answer any questions. And by the way, anytime anybody wants to call me, FaceTime me, speak to me on the phone, email me a question, text me a question, I give everybody my phone number. You're welcome. I think people, the more information people have, the better. There shouldn't be any secrets that anybody has, and people should have all information available to them. And again, anything that I tell people, I always say, listen, anything I've told you, go on the internet, Google it, cochlear dose, Google Gamma knife, Google, and you'll, there's ample opportunity for people to confirm, what's out there nowadays. And you can even watch any of these operations, just go to YouTube and you can watch it yourself. So, but I'm happy to help anybody anywhere in the world who wants advice on this or any other brain issue. And I'm happy to take questions at this point.
Great. Thank you, Dr. Brisman. That was really very informative. And we do have quite a few questions. The one that I saw most often was about the size of the tumor, which you addressed a little bit. But if you could give us a little bit of insight in your mind as far as what constitutes a large tumor. And another part of that question would be, if you have a smaller tumor that's pressing on the brainstem, does that affect your decision-making at all as far as surgery versus radiation?
Right. So the first is, I would say, you got to, show me the picture, because each person is different. Like, for example, when you say it's 3 centimeters, I would say, well, is it 3 centimeters by 3 centimeters by 3 centimeters? Or is it 3 centimeters by 1 centimeter by 1 centimeter? I mean, these come in all shapes and sizes. Also, is the 3 centimeters, are you including the part in the canal? Like, to me, the part in the canal doesn't even matter. That's tiny. And then you see it can get big within the cerebellopontine angle. Also, each person is different. A younger person may have a tighter brain, may have more compression, and some people, than others. But I would say, coming around 3.5, 4 centimeters, if it was 3.5, 4 by 4 by 4, but really each person has to show me. I had a patient who came to me, this is when I first started 20 years ago. He had a 4.2 centimeter acoustic neuroma that presented with hydrocephalus. He was unbalanced, and his hearing had decreased. So I had to put in a shunt, a ventricular peritoneal shunt, a tube from the head into the belly. And after that, he felt fine, other than his little decrease here. He was 70. His tumor was 4.5 centimeters. He said, what are my options? I said, well, we could do a big operation, or we could radiate, He's like, let's do that. And for him, I sent him for normal fractionation. We did him in 20 sessions, and he did fine. Like there was no rush on treating the tumor. It had been there for years. And years later, his tumor was 2.5 centimeters. It had dramatically shrunk. So I think it's really something that has to be viewed by somebody who does lots and lots and lots of these cases. But I would say, show me the picture, but there's no one number that answers the question. That's what I would say. But, once you start getting around 3.5, 4, and if it's 4 by 4 by 4, you start thinking maybe it should be debulked, or 3.5 by 3.5, but it has to be individualized.
Okay. And you talked about having, radiating a tumor, and then potentially, if it does grow back, in the rare occurrence that it does grow back, re-radiating. So we had a patient who had 2 separate treatments of CyberKnife, and still is now seeing growth after at 5 years after the last CyberKnife treatment. So is it possible to radiate a 3rd time? Would that be your recommendation, or would you then turn to surgery?
So again, I would need to see the images. Now people can have a little bit of enlargement after the treatment that could just be from the treatment itself. Again, I would say different doctors are going to get different results on these. I mean, I feel that my results, since I do, a very large volume, are going to be better than the people who have the radiation doctor do it, or do low volume of the stuff. But I would say there isn't too much literature on 3 treatments for an acoustic neuroma for focused radiation. Right. That having been said, I mean, anything can be considered. If it's truly growing, let's say this person is 75, and they're like, hey, and how big is it? Is it small? Is it medium size? I mean, one might consider it. A big consideration in re-radiation is, how long are you from the first treatment? The further out you get, the safer it becomes. So if somebody had 1 treatment, treating them 7, 10 years later is pretty safe. Whereas treating them 2 years later is much more likely to have issues with it. Or if it's pretty big and they're young, one might debulk it and then, radiate for any remainder. But again, I think it really has to be individualized.
Okay. And can you talk a little bit more about hearing preservation and outcomes, I guess, long term? We've heard that, or there was a patient question here that talked about surgery offering the potential for complete hearing loss, depending on what type of surgery is done, but that after surgery, you basically have the hearing that you're going to then probably have for the rest of your life. With radiation, does it tend to decrease over time, or is it the same thing? What you have after your radiation, you still have 10, 15, 20 years later?
Okay, so again, I'm of the opinion that unless the tumor is enormous, the Gamma Knife is better than the surgery for all parameters. Now, as far as the hearing for surgery, I mean, the hearing is very hard to preserve, particularly depending on how aggressive you're going to be. If you're going to try to remove the entire tumor and peel it off the nerve, I mean, I do a lot of operations for trigeminal neuralgia where we're not even working on the nerve. We're just waving hello to the nerve, and the nerve, we monitor the nerve, and the nerve starts, decreasing in function. So that nerve is very hard to preserve, particularly if it's a bigger tumor and if you're trying to remove all of it. So, I mean, I guess if that's a good thing that you've immediately lost all your hearing, I would say that's a bad thing. As far as Gamma Knife, I mean, I don't think anybody loses their hearing immediately, but over time, I would say there's about a 60 to 70% chance of preserving the hearing at the level that you came in with. And I think that chance is a lot better now that we understand, the correct dose, which is probably about 12.5 gray to the edge. And we know the importance of minimizing the dosage to the cochlea. That having been said, some people will still have decreased hearing, and it'll occur over time. Some of that decrease will be partial, and some of it will be complete, but it may occur over years. But I don't see why that would be worse than immediately losing your hearing, immediately, having a good risk of having facial paralysis and all the other risks. But that's been my experience. And I think, again, the hearing outcomes are much better, with an experienced person doing it. Now that I think a big advance is the dosing and the cochlear dose preservation.
Okay. And, you talked about the non-invasive nature of radiation and how patients can go home that day. What are some of the most common side effects that you see from patients, if you see any immediately, and then maybe, a couple of weeks after radiation, and then 6+ months later? What are your patients telling you?
Well, again, I'm going to say that my patients are telling me, I'm very happy. Thank you, doctor. But I mean, immediately there could be a little bit of a headache for a day or so, because we put pins in. There's a little soreness in the back of my head. There's a drop of numbness where you put the pin in. I mean, really, there isn't too much. Now, I will say there are other symptoms like ringing in the ear that I don't think necessarily will or won't get better with gamma knife treatment. I mean, so that may or may not improve that symptom. I would say I don't see, so right after the treatment, I don't see too much. I mean, down the road, people may still have some ringing in the ear. They may have some decrease in hearing, which is possible with or without the treatment. Again, as far as facial weakness, I mean, I think I had one person who had a little twitch for a week or two. I put him on steroids. I mean, I've seen nobody die. I've seen no one have an infection, even of a pin. I've had a stroke. I mean, like I said, there will be some people who say, I feel a little dizzy. I have some ringing, which they would or wouldn't have had beforehand. And sometimes I'll also say I will see patients, like let's say 6 months down the road, they may get a little swelling, say, hey, I have some headache, and I might put them on a course of steroid for 3 weeks, and it usually clears up. But I would say that for the most part, I'm not, I've not really seen any kind of serious thing, not at all like, brain surgery. I mean, look, I do brain surgery and I love doing it when it's necessary, but it's just, it's like, which is riskier, eating a scoop of ice cream or putting your head in the mouth of an alligator? I mean, even if you showed me a study showing that those two were comparable, I would say, come on, that's crazy. But my experience has been that people are very happy with their gamma knife treatment. Okay.
And what are you seeing anything new sort of coming down the pike as far as radiation? We know about, you talked about gamma knife and cyber knife, and we've heard about proton beam. Is there anything really new, or are those effective treatments and they're just, kind of what we're looking at?
So look, all can be okay. I mean, proton beam, I feel, is a bit of a gimmick. I mean, because people say, hey, we have a proton beam. I mean, it costs $10 million. You need a cyclotron. It's gigantic. And as far as I'm concerned, there's no evidence that treats acoustic neuromas or anything any better than these other machines. Again, as far as, can gamma knife result in the hands of an experienced person be beaten by someone with a linear accelerator? They can, or they might be comparable, but again, you have to have the right equipment. A lot of these linear accelerators are built to treat spine and lung and other things. I think some of the newest ideas are one, the dosage to the tumor and the dosage to the cochlea for hearing preservation. Two, the notion that if a tumor is huge and has to be removed, the idea of taking out 95% of it and leaving the rest for the focus radiation. And then I also think there's a notion of doing some fractionated focus radiation for tumors that are on the border. Like if I have a patient who it could go either way, I might treat them in 5 sessions rather than in 1 session. And I think that can be a little bit safer for a bigger tumor. But I think those are some of the newer ideas, and but again, I would say some of the old ideas are still hanging strong.
Okay. We have a couple patients who are observing their tumors and are on what we call watch and wait, and want to know how I guess, what is your typical patient's experience? Do you watch the tumor for any length of time before determining a treatment? And then have you ever seen a tumor shrink on its own without treatment?
I don't know that I've seen a tumor shrink. I mean, it could go, the radiologist could one day read it as 9 millimeters and a year later as 8, but that could just be variation from the radiologist. I don't know that I've seen them shrink on their own if they were really acoustic neuromas. I mean, if you see a small dot there and it goes away, maybe it wasn't an acoustic, it was some other inflammatory process. I think watching and waiting is okay, particularly if the tumor is not too big. And particularly if the person's older. I mean, the downside to the watch and wait is that the hearing loss is something that often does happen, and it can happen unexpectedly and suddenly. So you could wake up one day and have no hearing. If you treat the tumor while you have useful hearing, then there's a very good chance with Gamma knife you will preserve the hearing. Whereas if you wait until you have very poor hearing, it's unlikely you're going to get the hearing back. Now sometimes people will suddenly lose the hearing and then it gets better. But I'm saying if you have the hearing is lost and it's for a year, it's down to a very low level, it's unlikely it's going to get better after that. But it's up to the individual. I think it's okay if it's not too big. It's okay if they're older. As people get older, I say, look, you're 70 or 75, you get to do whatever you want. Whereas if the person's 20, I mean, I'm going to be more insistent and say, look, this would be wrong to leave this alone. But I think watch and wait is okay. But again, it depends a little bit on the size of the tumor. Does the person have, if they have no hearing, then, and the tumor's small, then I'd say it's more reasonable to watch and wait. But I think these are all individual decisions and observation. Surgery that aims to remove 100% of the tumor, various types of radiosurgery, 1, 5, 20 sessions are all acceptable treatments.
Okay. And you mentioned reading the MRI and having someone say, a very small tumor maybe shrunk because it wasn't there or something. We did have a question about getting a repeat MRI on a different machine and then having it read by a different radiologist and coming out with either growth or it shrinking, but most likely growth. How common is that when you're talking about a millimeter or two, that it's because it was on a different machine or it was read by somebody else, or does that in your mind count as growth?
Well, it may. I mean, I look at the images myself and try to decide. I mean, so, I'm going to look at it and say, look, I think this is growing, but a millimeter of growth doesn't necessarily guide my decision anyway. I mean, that's not the critical issue. The issues are more, how big was it to start with? What are the symptoms the person has? Is this an 80-year-old or is it a 20-year-old? Was there a lot of compression on the brainstem to start? But I think a millimeter or two either way is not likely the critical issue as far as decision making.
Okay. And you mentioned NF2 in your presentation. And can you talk a little bit about what goes into your decision making when somebody has 2 acoustic neuromas? We had a patient who had a total removal on the right side and is now experiencing deafness and facial paralysis on the right side, and has a 2.5 centimeter tumor on the left. So how do you move forward as far as radiation versus surgery in a case like that? Again, I'm sure it would depend completely on the patient and on the scans, but what sort of goes into your decision making when you're faced with decisions like that?
Right. So again, the NF2 patients, like the people who have 1 acoustic neuroma, I recommend Gamma knife for. I mean, the first tumor, I'm guessing, I mean, maybe it was enormous hearing or facial, but that having been said, the second tumor, if there is useful hearing, I do think that treating that tumor now makes sense because, once the hearing is gone, the hearing is going to be gone. What I would do though, as far as the treatment, is again, keep it on an extra low dose, maybe treat more like 12 gray, and make sure the cochlea gets a minimal dosage. Like you don't have to treat like a a small piece of tumor that's near the cochlea, you don't even have to treat that at all. Treat the part of the tumor that's threatening the, so I would try to keep it at a very, very low risk, but I probably would treat it. And also, I mean, unfortunately, because of this person's circumstance, it wouldn't be a bad idea to start, to learn sign language, because that's a possibility, is that there could be hearing loss. But I would recommend, doing a treatment with, again, probably 12 gray with minimal dosage to the cochlea, and probably, not even treating some of the tumor that's by the cochlea, but understanding that with treatment or without, it's possible the hearing will be lost. I mean, if the person's 90, I'd probably leave them alone. But I mean, if they're younger, then, I would probably do a treatment now, but there's different philosophies.
Well, and that's a tough one. That's a really, those are difficult cases. So, well, that brings us to the end of our time today. And that'll have to be our last question. Dr. Brisman, thank you so much for spending some time with us, for giving us all this information and answering all these questions. We did record the webinar, so we'll have that uploaded to the ANA site within the next day or so. We'll add permanent captions to that. Those will appear about a week from now. We are working on the spring webinar and Facebook Live schedule. So keep an eye on our events calendar on the ANA website at www.anausa.org, as well as on our social media to see what's coming. Thank you all for attending, and have a great day.